So, sir, should we start?
Sure.
So, good evening, everyone, and welcome to Oncology Academic Forum. Today, we will be having a case discussion on advanced carcinoma posterior pharyngeal wall. And we are privileged to have with us Cessal, sir. And we are really thankful to him. He has always been the backbone of Oncology Academic Forum throughout. And sir, we welcome you. And the case will be presented by Dr. Gayatri Prakash. She is a resident in radiation oncology in RCC Trivandrum. So over to you, Dr. Gayatri, and thank you, sir.
Thank you, sir. Good evening, everyone. I'm Dr. Gayatri Prakash, third year MD Radiation Oncology resident, RCC. Today, we will be discussing a case of advanced carcinoma posterior pharyngeal wall. Coming to the case, Mr. X, a 34-year-old gentleman, chronic alcoholic, working as a manual laborer with good performance status, presented with dysphagia of 2 months duration, odynophagia of 1 month duration. The patient was apparently normal 2 months back when he developed dysphagia to solids, and now the patient is able to tolerate liquids only. He also has pain on swallowing. During this period, he has no history of respiratory symptoms or any other symptoms. He came to our institution with an endoscopy report showing a bulge in posterior pharyngeal wall. The lesion is extending from left aryepiglottic fold, involving left pyriform sinus and up to the level of postcricoid. A biopsy was taken which showed well-differentiated squamous cell carcinoma. He was further evaluated from here. He was ECOG performance status 1 and all vitals within normal limits. Oral cavity and oropharynx, no trismus or ankyloglossia, no visible or palpable lesions, nose, bilateral ears normal, bilateral level 2 lymph nodes and right level 3 lymph nodes were found to be enlarged, and the right level 2 lymph node was 1.5 into 1 centimeter per mobile, right level 3 was 2.5 into 1.5 centimeter fixed node, and left level 2 was 1 into 1 centimeter per mobile node. On throat examination, laryngeal crepitus was absent and no stridor was noted, and the systemic examination were found to be within normal limits. Now we will briefly discuss on the CT net findings, and this is the level of base of skull. This is the internal carotid artery. This is the prevertebral muscles, and what we see here is the retropharyngeal region, and you can see an enlarged right retropharyngeal lymph node with a necrotic center here. On the subsequent cut, bilateral retropharyngeal lymph nodes are seen to be enlarged here on the left side and on the right side. At the level of mandible, what we see here is the level 2 region. On the medial aspect of sternocleidomastoid, we can see an enlarged right level 2 lymph node and 2 small left level 2 lymph nodes here. On the caudal cut, this is the hyoid bone. So at the hyoid level, this is the valleculae, and this is the epiglottis, and this is the aryepiglottic fold on the right side and on the left side. And we can see there is an asymmetry between both the aryepiglottic folds, and on the left side, and this is the posterior pharyngeal wall. It's thickened. So the lesion starts from this cut and it extends to the left aryepiglottic fold. Here also we can see bilateral enlarged level 2 lymph nodes. And towards the lower border of hyoid, we can see the lesion in the posterior pharyngeal wall, and the lesion seems to have loss of fat plane with the prevertebral fascia. Also, the right level 2 lymph node seems to have extracapsular extension at this level. In the level, what we see here is the thyroid notch level. This is the pyriform sinus on the right side, and on the left side, we can see an obliteration of the right left pyriform sinus And the posterior pharyngeal wall lesion is also here. And also this is the false codes, and the lesion extends up to the level of left false code. And this is the right level 3 lymph node here at the thyroid level, and the lesion seems to have extracapsular extension at this level. Also on the left side there is a small left level 3 lymph node here, and the last cut is the cricoid level. The hypopharynx posterior to the cricoid region is the post-cricoid region. So the lesion extends up till here. So summarizing, this is a soft tissue mass lesion in the hypopharynx involving posterior pharyngeal wall, left araepiglottic folds, false vocal cord, left pyriform sinus with loss of pad plane with prevertebral fascia. Bilateral level 2, 3 and retropharyngeal nodes are enlarged, and on the right side level 3 lymph node has an extracapsular extension at the level of thyroid nodes. A CT thorax was taken as the patient had a level 3 lymph node with extracapsular extension, and also the lesion is extending up to post-cricoid region and was found to be within normal limits. Baseline blood investigations including creatinine clearance were all within normal limits. A dental prophylaxis was also done. And summarizing the case, this is a 34-year-old gentleman, chronic alcoholic with good performance status, diagnosed with biopsy-proven well-differentiated squamous cell carcinoma hypopharynx, stage C-T4B, N3B, M0. C-T4B in view of prevertebral fascia involvement, and N3B in view of extracapsular extension. So how to proceed further in this case will be discussed by Dr. Cessal Thomas, Additional Professor, Radiation Oncology, RCC. Over to you, sir, for further discussion.
Gayatri, can you close your window? Thank you. Can you hear me?
Yes, sir, you're audible.
Thank you very much. Okay, so she has presented the relevant history, the clinical examination findings, as well as the CT scan. So I will go through the how to approach a patient with an advanced hypopharyngeal tumors. So that will be the topic of your discussion today. So I will discuss how to approach a patient with advanced hypopharyngeal tumors. What all investigations to be done, how to decide the treatment, how to go forward to radiation, chemoradiation, or to do surgery followed by adjuvant treatment. Then how to approach in a very advanced disease where the radical approach is not possible. And more on also the patients for the imaging, what are things you have to check, or the target orientation as well. So any patient with a suspected, how the advanced the hypopharyngeal tumors what are the features and how they differ from CL larynx, which is a very close structure. Most of the hypopharyngeal tumors are later presentation because they present with T3 or T4 disease at presentation. And heavy nodal involvement. Most of the patients will have level 2, level 3 nodes, and level 5 node can also occur in tumors. So this is a heavy nodal involvement. In certain small percentage can also present with distant. Major concern in a patient with hypopharynx is nutritional complex, because most of the patients will have a nutritional complex. And this patient initially had the intolerance to solid food. Then when the patient came, the patient was able to tolerate semi-solid diet. Then poor organ preservation rates compared to larynx. And when we treat any patient with larynx or hypopharynx, the organ preservation rates were the 5-year survival is poor compared to stage-wise comparison with larynx. There is high chance for relapse, even if patients who attain complete clinical remission with chemotherapy. Then you consider them for radiation or chemoradiation based on the European guidelines. Still, there is a high chance for relapse. And compared to larynx and hypopharynx, the salvage rates poor in hypopharyngeal tumors. And complications are also higher. The salvage surgery complications are also higher in patients with CI. If you look into the relapse pattern, the systemic relapses also can happen after the treatment for hypopharyngeal tumors. this 5-year survival, stage-wise survival is also poor. That's how the CL larynx and hypopharynx differ in, although they are very adjacent structures. And if you look into the staging, the larynx is mainly staged by this subsite involvement. Suppose a lesion in the supraglottis extending into glottis, then it becomes T2. Whereas in hypopharynx, it is T1, T2, T3 is mainly the size criteria. So T1 is less than 2 or equal to 2 centimeters. That is T1. T2 is 2 to 4 centimeters, or a lesion extending into the supraglottic larynx. And T3 is any tumor more than 4 centimeter, hemilarynx fixative, or the tumors involving the cervical spines. T4A of larynx and hypopharynx are the same. Only slight difference, because most of them, T4A and T4A, are advanced disease stage BC. So any patient who is suspected, most of them present with dysphagia or difficulty in odontophagia. And most important thing is the performance status evaluation is very important. The patient is having a poor performance status. The patient may not tolerate the treatment, although the patient may have at least these things. Performance status, nutrition status is very important in a patient with hyperphagia. Detailed clinical exam, especially you need to properly evaluate the history. What about the dysphagia? What is the extent of dysphagia? Then any pain during swallowing is present. When the patient is having hoarseness is present. The patient can have swelling of the neck. That is due to
sorry to interrupt, sir. Hello. Sir, your voice is not audible.
Okay. Can you hear me now?
It's better, sir.
Okay. Yes. Sorry. The other thing is you need to check whether the patient is having a clinical examination. What about the lymph nodes before doing an indirect laryngoscopy or endoscopy? Then you have to do proper clinical examination of the any lymph nodes are present. What about the laryngeal framework? Whether the laryngeal framework is enlarged, displaying of the thyroid cartilage. What about the laryngeal crepitus? Whether it is present or absent. Whether the patient is having any features of any airway compromise. Patient is having stridor. It's all things you have to bear in mind when you examine a patient. Then when you do a IL by yourself or a 7-endoscopy in your office, or you do send the patient for the head and neck concourse for a flexible endoscopy, this is what you need from the endoscopy evaluation. You need to know where is the primary site, whether it is from the piriform sinus or where it is a supraglottic tumor extending into piriform fossa, whether the lesion is present in the posterior pharyngeal wall, the post-cricoid area. These are very important. Second, what about the nature of the growth? Whether it is the proliferative tumor, ulcerative disease. The superior extent, whether superior and inferior extent, this is very important for deciding the target volume delineation, deciding the treatment, putting the radiotherapy, portals, etc. Then extension into larynx. Okay, a hypopharyngeal lesion extending into a larynx, then it becomes T2. What about the mobility of the vocal cord? The T1, the impaired mobility or is not included in the state. But once the hemilarynx is fixed, then it becomes a T3 in hypopharyngeal tumors. If a patient is having a piriform sinus tumor, what about the extension of the post-cricoid, the cervical esophagus is or not? Whether any airway compromise, is there any signs of aspiration? These are all important for deciding the treatment. So this is what we need from the endoscopy. So coming to the I know every one of you, each one of you know this, the evaluation, you know this is the epiglottis, then you have the lingual surface, okay? Then this you have the base of ring here. Then this is the epiglottis, this is the arachnoid, so this should be the array epiglottis. Connecting the epiglottis and the arachnoid, this is the array epiglottis. And little down at the level below the arachnoid, you have the cricoid. So behind this area becomes the cricoid area. And this is the piriform fossa. Here this is a piriform fossa on both sides. Okay. And you have, this is a false cord, this is a true. So you have the epiglottis here, you have the array epiglottic fold, this is the arachnoid cartilage, and you have the post-cricoid area that I will show you in CT scan. You have, this is a piriform fossa. So these are the things you have to check when you do that. And then after that, you do a flexible endoscopy and take a biopsy. Or if a patient is having, say, or if a patient is having endoscopy shows lesions, and if the patient had undergone an FNAC, most of the hypoflavic tumors will have this. So in this group of patients, whether to consider a flexible endoscopy biopsy, then if the biopsy can be done without compromising the airway, or it will lead on to tracheostomy, better not to do a biopsy. Otherwise, from the biopsy, so after the biopsy, so you can do a CT scan. So you can argue that you should do a CT scan first, then you go for the biopsy. That's also fine. So most of the time, the patients are diagnosed and referred to cancer. So most of the time, the patient will have an endoscopy done outside, and the biopsy, with the result, the patient is referred. So after that, for evaluation of larynx and hypopharynx, the investigation of choice is a thin slice, the CT scan. That's the standard. There is the CT scan also, that is the standard investigation for evaluating the local external disease. The MRI is the investigation in nasopharynx and hypopharynx, whereas in larynx and hypopharynx, CT is a better. For evaluation of the cartilages in larynx, the sensitivity is better with MR, but the specificity is better with CT scan. So specific CT scan is more specific, and most of the details can be, the extent can be delineated by the CT scan. Then you have to do an barium solo, you have to do an X-ray test. In certain situations, you have to do a CT products. The patient is having lower survival, so the patient is having level 4 lobes, or you feel that the patient is having extent of going down to the post-critical cervical esophagus, then you need to do an evaluation of the CT products as well. Or if the patient has the symptoms suggestive of synchronous primary attack, like the patient is having breathlessness or any features of symptoms of CLR or clapping, then you have to and a routine PET scan for staging is not recommended. Then you have to do, there is no need to do a bone scan, there is no need to evaluate a liver by doing ultrasound or CT scan. Dental prophylaxis is required, and you have to do a baseline evaluation of the hemogram, the renal parameters, including platelets, liver function test, and all of the baseline investigations before this. Now coming to the evaluation of the CT scan, this is very important. All patients with hypopharynx, those who plan for radical approach, require a CT scan. But if a patient is planned for diabetes, a patient is having very poor performance, then it may not be, the CT scan may not be such situations. So what is the extent of the hypopharynx? It extends from the hyoid bone. This is the hyoid bone. So whenever you want to know the radiological anatomy of larynx and hypopharynx, you need to know the one bone, two cartilages. There is one hyoid bone. This is the thyroid cartilage. And this is the thyroid cartilage. And below that, that's the trunk. So this is the anterior aspect. This is a posterior. We can see the epiglottis here. This is the epiglottis, and this is the hyoid bone. And hyoid bone is connected anteriorly and laterally by membranes, ligaments. And then the thyroid and the cricoid is also connected by the attached by the ligament. And from this hyoid to the caudal edge of the cricoid. So this is from here to here. This is the extent of the hypopharynx. And you need to know certain, this is the cricoid, this is the arachnoid, this is the cricoarachnoid joint. The cricoarachnoid joint is the functional larynx. Okay, I will show you the hypopharynx because radiologically we need to learn the larynx and hypopharynx together. That's why I'm saying the larynx part also. Coming to the extent, so when you take a sagittal view of the oropharynx and larynx, this is the base of tongue. This is the clavicle. This is epiglottis. The epiglottis is part of the supraglottis, and this is the pharynx. So this from this area to the caudal edge of the cricoid. This is the lower.
Sorry to interrupt you, sir. The mic, there is interruptions in between.
Okay. Can you hear me now?
Yes.
Okay, wait. Okay, I think my sound I have placed very low. Okay, yes. Okay, now you can hear me now better.
Yes, sir.
Okay, sorry. Okay, the volume was low. I'm sorry. Okay, so in this is the superior extent. This is the superior extent. The inferior extent is the caudal edge of the cricoid cartilage. The caudal edge of the cricoid cartilage is to know the lower limit of the hypopharynx. At the same time, it is the lower limit of the the caudal limit is the caudal limit of the is level 3. Okay, so that is the level 3 anteriorly, and posteriorly it is the caudal limit or the is a 5A 5B junction. So it's a level 3 level 4 junction at the caudal edge of the cartilage. That is anteriorly, and so in this cut you can say, and posteriorly it is a 5A and 5B junction. That is the caudal edge of the cricoid cartilage. So when you take a CT scan at the hyoid and at the level of the thyroid, so we will discuss that. So this is the hyoid bone. Okay, this is the hyoid bone. Behind the hyoid bone, there is a space called the pre-epiglottic space. I will go back. This is the pre-epiglottic space. The pre-epiglottic space is superiorly by a ligament called the hyoepiglottic ligament. This is the hyoepiglottic that you cannot see in CT. Okay, I'm arbitrarily saying that below that is the pre-epiglottic space. So this is the pre-epiglottic space. So if we have any tumor in the oropharynx going into this area, pre-epiglottic space, then this becomes a T4 area. This becomes a T4 area. Okay, up to the lingual surface of the epiglottis, it becomes a T. Whereas if you have a lesion in this area going into the vallecula, then it becomes a T2. Okay, so this is the hyoid bone. And behind that, there is the space called the pre-epiglottic space. And the Dr. Gayatri has shown with the vallecula, this is a vallecula. Okay, on both sides, this is the median glossoepiglottic fold. This is the median glossoepiglottic fold, which you see in a CT scan. And on either side of the median glossoepiglottic fold, you are seeing vallecula. And this is the free edge of the epiglottis. This is the free edge of the epiglottis. So you are seeing a free edge of this is the epiglottis. Then behind that, so this is the array and the pharyngeal epiglottic fold, and this is the lateral pharyngeal. This is the lateral pharyngeal. That is how you see in a CT. This is called glossoepiglottic fold. That's a pharyngeoepiglottic fold or lateral glossoepiglottic fold. So this is the lower limit of the pharynx. Okay, sorry, lower pharynx. This is the epiglottis. And this area, this is the piriform fossa. Okay, so coming to this is the pre-epiglottic space. This is the hypotenuse area behind the hyoid bone. That is the pre-epiglottic space. And this is the median glossoepiglottic fold. This is the vallecula. This is the array-epiglottic fold, and this is the piriform fossa. So this is a piriform fossa, and then you have the posterior pharynx. This is the posterior. This is the posterior. Okay, so then behind the posterior pharyngeal wall, there is the pharyngeal constrictor muscle. When you see any pharyngeal constrictor muscle at the level of the hyoid bone, this is a middle constrictor. Okay, and if you see any constrictor muscle, that's constrictor muscle at the level of the hyoid and the thyroid cartilage and cricoid cartilage, then is an inferior constrictor. An inferior constrictor is more bulky compared to the middle constrictor. So this is the pharyngeal constrictor. Okay, suppose if you draw, this will be like this. So that is a pharyngeal constrictor, and this is a middle pharyngeal constrictor. And behind that, you have the prevertebral muscles. You have the longus colli muscle. It's the longus colli muscle. Okay, so that is the radiology anatomy. So in this cut, you are seeing two areas. This is a piriform fossa. This is a posterior pharyngeal. The hypopharynx has three subsides. One is the piriform fossa. Second is the posterior pharyngeal. And third is the post-cricoid area that I will show you. So in a cut which is lower, this is the pre-epiglottic space. The pre-epiglottic space is continuing laterally as the paraglottic space. This is a space and this is hypodense because the fat is there. And this is the array epiglottic fold. This is the piriform. So the array epiglottic fold forms the medial boundary of the piriform fossa, and lateral boundary is formed. I will show you that. This is the lateral boundary. This is the piriform fossa. This is a lateral boundary of the pyriform fossa is formed by the mucosa covering the medial aspect of the lamina of the thyroid cartilage. So this is the thyroid cartilage, and this is the medial aspect of the lamina of the thyroid cartilage. This is the mucosa covering. That forms the lateral boundary of the pyriform fossa. Medial it is formed by the aryepiglottic fold. That is the, this is the medially it is formed by the aryepiglottic fold. That is the, then you have the, in this level also the thyroid cartilage. This is the thyroid cartilage, and you have the hyoid-epiglottic liquid that I have already shown. This is the paraglottic fold. It's a paraglottic fold. The pre-epiglottic space containing the lateral is the paraglottic. Here, this is the aryepiglottic fold, and this is the pyriform fossa. Again, you have the pharyngeal constrictor muscle, and the pharyngeal constrictor muscle here in the thyroid cartilage is nothing but the inferior constrictor. Okay. Now you have the at the level of the glottis. You have it at the level of the glottis. So at the level of the glottis, the main how you identify is by the crico. This is the arachnon. This is the cricoarachnoid joint. This is cricoarachnoid joint. Yeah, that is a functional. And behind that, you have this is the you have the cricoid. The area behind the cricoid, that's a post-cricoid area. This is also part of the. At the level of the glottis, you can see the muscles. That is a vocalis muscle. This is the thyroarachnoid muscle, and the medial belly of the thyroarachnoid muscle is called the vocalis muscle. So this is the vocalis muscle, and you have the ligament. This is called the vocal ligament, which extends from the arachnoid cartilage to the thyroid cartilage, and this is the anterior commission. Another important structure which you see in the at the level of the glottis is the apex of the pyriform sinus. So you have an apex which is more broader in the superior aspect of pyriform sinus, but it is narrow at the glottis. That is narrow towards the lower aspect. That is pyriform fossa. So if you look, this is the cricoarachnoid. This is the arachnoid cartilage. This is the cricoid cartilage. This is the oral. This is the apex of the pyriform. So this is at the level of the true glottis. How you make out, because you can say that is a cricoarachnoid joint. That is how you make out because the at the level of the true glottis. And this is the apex of the pyriform fossa. Now, so the structures in the hypopharynx are one, the area posterior to the cricoid cartilage. Then second is the pyriform fossa, and third is the posterior pharynx. And the structures in the supraglottic area are one is the epiglottis, second is the aryepiglottic fold, then you have the arachnoid cartilage, you have the false cord here, you have the false cord. Okay, I will show you in the subsequent when we discuss the CT scan of the patient. Okay. So you have the middle constrictor muscle. The middle constrictor muscle, because you are contouring the middle constrictor, that is why I have given as one slide for middle constrictor and inferior constrictor. The middle constrictor, this is the middle constrictor, this is the inferior constrictor, and the inferior constrictor, the middle constrictor arises from the, this is the hyoid bone. This is the hyoid bone. Hyoid bone has a greater conum and you have a lesser bone. And this and the middle constrictor arises from the greater conum and the lesser bone, and also the stylohyoid ligament, and it is getting inserted into the median raphe in the posterior aspect. Okay, so that is the insertion of the muscle. And if you look into the inferior constrictor muscle, it arises from the lamina of the thyroid cartilage and also the cricoid cartilage. Okay, this is the inferior constrictor muscle. Inferior constrictor, which arises from the lateral aspect of the lamina of the thyroid cartilage on both sides. So this is the inferior constrictor. Again, it is inserted into the median raphe. So this is the superior constrictor. Superior constrictor is more or less involved with the nasopharyngeal and the oropharyngeal malignancies. It has nothing to do with the hypopharyngeal malignancies. Now coming to the management of the early disease although the case for discussion today is advanced, we have to learn about the management of early disease as well. The T1, N0, T2, N0. T1 is less than or equal to 2 centimeters, and T2 is 2 to 4 centimeters, and it is with a mobility of the body. It is not fixed. At the same time, it may extend. Generally, they are treated by a single modality, either radiotherapy or surgery. And in this group of patients, most of the patients present with advanced disease. A T1 N0 and T2 N0 means the nodal involvement. Early hypopharyngeal tumors without nodal involvement are less compared to the advanced disease administration. They are either treated by radiotherapy. When you treat with the radiotherapy, generally we need to consider the primary plus a bilateral neck treatment. Elective neck treatment should be given level 2, 3, and 4 on both sides should be treated because it's a midline structure. And you can also be treated by a open partial pharyngectomy, or it may be a robotic assisted, or it may be a laser assisted. So, but you have to consider a neck dissection as well, because there is a high chance for a lymph node involvement. If a patient undergoes surgery, the patient may become a candidate for adjuvant radiotherapy, either because of the margin close or due to node positive. So, in that situation, it may be better to treat the patient with a definitive radiotherapy. Now, coming to the normal piriform scans. This is a normal piriform scan. So that I said, this is the medial boundary of the piriform scans by the lateral boundary of the areoparotic fluid. And the lateral, it is the mucosa covering the inner aspect of the medial aspect of the lamina of the thyroid. So this is the normal piriform scan. And this is a tumor. You can see a lesion in the left, right piriform fossa. The lesion is extending into the paraglottic family, but a lesion in the supraglottis is extending into paraglottic family or pre-epiglottic species. But in hypopharynx, it is only by size criteria. The lesion is also extending into the posterior pharyngeal wall, and it is not crossing the midline. So this is a posterior pharyngeal wall. Lesion is extending into the posterior pharyngeal wall. The cartilage seems to be intact, extending into the supraglottic larynx. But if it is not hemilarynx, because it is not there, then it is staged by a size criteria. Generally, it is treated by radical or surgery. In most of the situations, although surgery is a theoretical possibility, in majority of the situations, it is treated by radical. Now, coming to the little more advanced disease. Now you can hear me better, right? Sound is better, right?
Sir, in between it was not. Just please keep the mic near so that the voice is okay.
Okay. Thank you. So in patients who have a little more advanced disease, like say T3 disease, or patients who have node positive disease, you have two options. Either you consider induction chemotherapy and reassessment, or you consider concurrent chemoradiation as organ preservation, or you consider partial laryngopharyngectomy plus negative. It is conservation surgery followed by adjuvant treatment. The two organ preservation approaches, one is induction chemotherapy and concurrent chemoradiation. Okay, there is no head-on comparison. There was a head-on comparison, and it was shown that the organ preservation is better in patients with concurrent chemoradiation, but there was no difference in the outcomes. But the number of patients were very less in that. So there are two approaches are there. One is induction chemotherapy and reassessment. Other is concurrent chemoradiation. And if you look into what I personally feel is that in T1 and T2 disease with node positive disease, concurrent chemoradiation may be better. A patient with a T3 piriform fossa is based on there is an EORTC trial addressing only the T3 piriform fossa that I will discuss. The induction chemotherapy may be better. In those patients who are receiving induction chemotherapy, based on the EORTC protocol, the patient should receive complete clinical remission, either complete clinical remission or stable disease, improved in the complete clinical remission, and the neck should be improved. That is complete CR. Then only you will consider radical. So that is based on a European trial that I will discuss. So if you have a partial response, also you can consider concurrent chemoradiation. That is based on another French trial. That is also a category 2 recommendation. This is in patients who are receiving induction chemotherapy. Okay, coming to the clinical trials, which I discussed, this is the URTC trial, which was initially published in JNCI in 1996, which was updated in Annals of Oncology in 2012. T3 pyriform sinus tumors, patients were randomized to surgery followed by postoperative radiotherapy, or patients were given induction chemotherapy, 2 cycles of cisplatin and 5-fluorouracil. And after 2 cycles, the patient who didn't achieve a partial response were offered surgery followed by post-operative radiation. And the patients who are offered CR or partial remission were offered 1 more cycle of induction chemotherapy. Then the patients were offered radical. So the main criteria, prerequisite for taking radiotherapy in the URTC trial was the patient should attain complete clinical remission with at least 3 cycles of chemotherapy. So if the patient had no CR with 3 cycles of chemotherapy, they were offered surgery followed by postoperative radiotherapy. The problem is the patient should be willing to undergo surgery. The patient is not achieving CR. Sometimes the patient may present with a near total dysphagia, or patient may be able to tolerate only liquids or semi-solid diet. You give induction chemotherapy, they will start eating solid diet, and they may not be willing for surgery if the patient is not attaining CR. Okay, that's another, the proper counseling before this approach. And when they analyzed, just found that the 3-year laryngeal preservation in patients who received complete CR with at least 3 cycles of induction chemotherapy was 42%. And there was no difference in survival between the 2 arms. That is, patient who received induction chemo followed by reassessment or surgery followed by postoperative. When they reported the long-term results with the 10-year follow-up, it was found that, published in Annals of Oncology in 2012, it was found that those patients who received induction chemotherapy, the 10-year survival was 13%. And those patients underwent surgery followed by postoperative radiotherapy, the 10-year survival was 10%. It means it is a bad disease. It's a very bad disease. The patient all received induction chemo and patient achieved complete CR. Then only the patients were given. Still, the patient had only, the 10-year survival was only 13%, even in patients who achieved complete CR. Then there was another question, can we improve the results by using a 3-drug compared to a 2-drug? And this included larynx and hypopharynx patients also. This trial is called the CORTEC 2001 clinical trial. And the primary objective of this clinical trial was laryngeal preservation. The secondary objectives were overall survival, progression-free survival, and toxicity. This was initially presented in ASTRO annual meeting in 2006, and which was published in JNCI in 2009 and updated in the same journal, that is Journal of National Cancer Institute in 2016. This is comparing 3 cycles of PF versus 3 cycles of T. And at a median, when the data was updated in JNCI in 2016, it was found that at a median follow-up of around 100 months, the laryngeal preservation was better in patients who received 3 drugs, that is TPF compared to PF. And also the larynx dysfunction-free survival was also better in patients who received 3 drugs compared to 2 drugs. But there was no difference in overall survival, overall control, or overall disease-free survival in patients who received 3 drugs compared to 2 drugs. This was published in JNCI in 2016. Now, I said you have 2 options. Either you consider induction chemo and reassessment. Either you can go for the URTC trial design, you attain complete CR, then you give radiotherapy, or you give 50% regression, then you give radical chemoradiation based on the CORTEC 2001 trial. Although this trial has not been incorporated in the NCCN guidelines because the number of patients were only 110 each, although it was a phase 3 trial. Now, the second option I mentioned was concurrent chemoradiation. This is based on the McKenzie meta-analysis, and there is only one trial evaluating the role of induction chemo followed by radiotherapy versus concurrent chemoradiation. This was published in ACTA Oncology in 2000, ACTA Laryngology in 2010. There is a trial around 75 patients. The study was eventually closed, and comparing the induction chemo followed by radiotherapy versus concurrent chemo, it has shown that the patients who received concurrent chemo had a better laryngeal preservation compared to patients who received induction chemo followed by reassessment. The second is the McKenzie meta-analysis. It was you have 2000 McKenzie meta-analysis. Again, you have 2009. Now you have 2021 update, which published in Green Journal in March 2021.
This is locoregional treatment basis locoregional treatment plus chemotherapy. What is the role of chemotherapy in the locally advanced cancer? The primary endpoints were event-free survival, locoregional failure-free survival, 120-day mortality, distant failure, cancer, and no cancer mortality. And it was found that the concomitant had a better outcomes in terms of hazard ratio of death. Means hazard ratio of death was 0.83. In terms of absolute benefit was 6.5% at 5 years and 3.6% at 10 years. And this was quite statistically significant. Event-free survival was better. There was no increase in 120-day mortality by incorporating concomitant cisplatin. Locoregional failure was also better in patients who were concomitant compared to local treatment. But there was no reduction in distant failure. The value was not significant. So that was the conclusion of the concomitant. So there is an event-free survival better. There is a locoregional failure, it was better. There is an improvement in survival. Those patients who received concomitant compared to locoregional treatment. When you give induction chemotherapy, there is no difference in terms of either death or there is no in terms of a head and neck cancer mortality. But there was a benefit in terms of reduction in distant metastasis, and also there was a trend towards improvement in local. The value was not significant. Only there is the positive thing in the induction chemotherapy was a significant decrease in distant failure. And when we look into the adjuvant chemotherapy, it was a negative impact. The hazard ratio of death was 1.02. And it was a 120-day mortality was hazard ratio was 1.89. And although it had a reduction in locoregional failure and also a reduction in distant metastasis, due to increase in 120-day mortality, there is a negative impact of giving adjuvant chemotherapy. Comparing concomitant versus induction chemotherapy, the concomitant had better overall survival, event-free survival, and locoregional failure. All were statistically significant with p-value. And the absolute benefit compared to concomitant versus induction chemotherapy was 6.2% at 5 years. Its p-value was significant. Event-free survival and locoregional failure were also less in patients who received concomitant compared to the induction chemotherapy. And there is a site-wise meta-analysis which was published in Beanchan in 2011. It showed that if you give induction chemotherapy in hypopharyngeal tumors, the benefit was 5.3% at 5.3% at 5 years, and the concomitant it was 4% for tumors. Now, if you are interested, you can go through one of our chapter contributions very recently in the book, The Pharynx Diagnosis and Treatment. One of my senior resident, Dr. Farida, has written the chapter. The whole team is contributed. Now, coming to patients who have a patient with T4 disease, it was first we discussed T1N0, T2N0. Second is T2, T3 with node positive disease. The third group is T4 disease, patient who have cartilage destruction. The standard treatment is to consider a surgical management followed by post-operative radiotherapy. In this group of patients, either concurrent chemoradiation or induction chemotherapy and reassessment considers category 3 recommendation means is not recommended. So generally, these patients will go for surgical treatment, and this is the only upfront absolute indication for doing an upfront surgery in CA hypopharynx. In T4 with cartilage destruction, then you go for a partial pharyngectomy plus a total laryngectomy, bilateral neck dissection plus bar minus reconstruction followed by post-operative. In advanced disease like in larynx or hypopharynx, it is difficult to know where is a primary site, whether it is a piriform sinus or where it is a supraglottic larynx extending in the piriform. Generally, they are treated by surgical management. And this is a through cartilage destruction is present. In this group of patients, we need to evaluate the CT scan. You need to check certain points. One, what about the prevertebral fascia? In this patient, the prevertebral fascia is intact. Second is what about the internal carotid? Third is what about the extent of the anterior extent? Because this is important to know whether suppose the skin is involved. Then you have to use a flap for a reconstruction. Other thing is the patient who have a thyroid gland involved, whether to do a thyroidectomy. So these are the important things you have to check in a CT scan of a patient like this. And then you consider surgery followed by a planned post-operative. The patient should have enough reserve to undergo surgery and post-operative. Then only you should take the patient for surgery. Now, in patients who have advanced disease like T4P or N3 disease, generally they are considered for palliation. Very advanced disease like a preventable involvement, posterior pharyngeal wall involving the supraglottic larynx, and patient with a compromised airway, or a very advanced disease like patients involving the whole of the larynx and pharynx, a hyperpharynx, generally they are considered for palliative. But selected T4P or N3 disease can be considered for radical approach. And patients should have good performance status, young patient, low volume disease, absence of heavy nodes, good social support, and highly motivated patient. So if this patient had a left pyrethroid disease involving the area with multiple matter nodes, so it may be a T2N3 disease with matter concentration. So is it not a very bulky disease? Nodes are also not that bulky. Then generally this patient will go for a contamination approach. Here this patient had, you can see the right pyrethroid fossa very clearly. The left is replaced by a tumor, but there is no through one through cartilage. But this patient had a pre-vertebral fascia involvement, minimal pre-vertebral fascia involvement. So, and this patient had a low volume disease, an absence of heavy nodes. Generally, this patient will go for a radical despite chemotherapy. So, coming to the contouring of the, I will take another 10-15 minutes for discussing contouring. So for this patient had a lesion in the right. They said the patient had a lesion in the posterior pharyngeal wall, extending into the array epiglottic fold, also into the left, the pyrethroid fossa. And patient had the pre-vertebral fascia was involved. So it's a T4P disease. The patient had a suspicious extracapsular extension at the level 3 on the right side. So it is an N3 disease. Now, before considering the contouring, these are the two landmark papers. Okay, I'm not going into the details. This was published in 2018. The first paper, that is the delineation of the primary tumor in the CTV in the larynx, hypopharynx, oropharynx, and oral cavity, the definitive treatment, and also the selection of lymph node target organs, the definitive treatment of head and neck cancer, and update by Vincent in 2019. So I will discuss the how a hypopharyngeal tumor is contoured based on the international guidelines, and then I will take up the case. First, you have a disease there. This is the pyrethroid fossa. This is the left pyrethroid fossa. This is the right pyrethroid fossa. Extending in the supraglottic larynx, you have this very enhanced lesion there. The pre-vertebral seems to be intact. So if a patient is having more than 4 cm or hemilarynx is fixed or a lesion extending in the cervical esophagus, then it becomes a T3 disease. In this group of patients, so you contour, this is the GTV, what you see in the CT scan. Then you give 5 mm margin, so that is your CTP1. Then you give another 5 mm, that's your CTP2. Or the blue one is a GTV plus 1 cm margin. So you can edit it based on the international guidelines. Where all you will edit. One, you can edit from the pre-vertebral muscles. This is the longest collar muscle. You can edit from that. Number 2, you can edit from the air cavity. The third thing is you can edit from the hyoid bone, and also this is from the hyoid. You can edit from the cartilage and the bone. And this is the guideline says. So the CTVP1 will be, so you give GTV plus 1 cm, that is CTVP2. So CTVP1 will be 5 mm, then another 5 mm, that will be CTVP2. But editing, so you can edit the air cavity, you can edit the pre-vertebral muscles here, you can edit from the gland also, submandibular gland here, but you have to include the pre-epiglottic space here. So that is your CTVP2. I'll give you another example in the posterior pharyngeal wall in the guideline. So this is a posterior pharyngeal wall. The posterior pharyngeal wall lesion can be either at the level of the oropharynx or at the level of the hypopharynx. This is mainly the lesion is seen at the level of the oropharynx, and it is coming down to the level of the hypopharynx. So you know that the hypopharynx starts only here. Okay. So this part is the oropharynx. So oropharynx going into the hypopharynx. And if a lesion in the oropharynx, the pre-vertebral muscle involvement is not considered T4P because In the staging of oropharynx, the prevertebral muscle is not mentioned. So this is the lesion. This is your GTV. Then you have the CTB-P1. Then you have the CTB-P2. The CTB-P1 you can edit from the vertebra. You can edit from there. But since the prevertebral muscles are involved, the prevertebral fascia is involved, the prevertebral muscles also should be taken. And you can edit from the air cavities. You can edit from the air cavity. So this is your final CTB. This is your final CTB2. I do not know whether you are able to make out that. This is your CTB2, not this one. So again, I will say it is edited from the soft palate, it is edited from the epiglottis, also edited from here, and also from the vertebra. So it's edited from the vertebra, edited from the soft palate, edited from the epiglottis, and also edited from the medial pterygoid muscle. This is a medial pterygoid muscle. Can you see that? It's a medial pterygoid muscle. So editing based on. Now coming to this, the particular case which we discussed, okay, you can see that this is an enhancing lesion there, although the contrast is not that good. Okay, so you can see this is the lesion there, and when you come to this will be your GT. Okay, this is at the level of the epiglottis. You can see at the level of the epiglottis. This is the base of it. You can see the base of it. You can see small nodes here, and small nodes level 2 regions, and this is the level 2 region. And that it extends from the posterior edge of the submandibular gland, medially the medial edge of the internal artery, and the scalenus muscle. Then laterally, it is medial edge of the sternocleidomastoid, and also the skin and the posterior belly of the digastric in certain parts, and also the parotid gland that forms the lateral boundary of the level 2. So extends from the caudal edge of the semen vertebra to the caudal edge of the hyoid. So you have two small nodes. I will show that. So this is the first. I will discuss only the contouring of the primary GTV. Now this epiglottis, this is vallicular, the median epiglottic fold here. You can see the GTV here. The node becomes more round here, small nodes. And this is submandibular gland. Okay. And this is the GTV. Coming down, vallicular, this is a free edge of the epiglottis. This is a pharyngeal epiglottic. The pharyngeal, just extending into the pharyngeal. Pharyngeal epiglottic fold, this is the GTV. You can see the lesion there, just extending into the pharyngeal. So this is your GTV. Now coming down to the level of the pre-epiglottic space. There's a pre-epiglottic space continuing laterally as the paraglottic space, epiglottic fold. This is asymmetry is there compared to this side. You have to think that this left epiglottic fold is important. Maybe you'll see it in the next slide. Okay, so this is the arachnoid cartilage. This is arachnoid cartilage. We have started seeing the arachnoid cartilage. That's also node has become more prominent here. Another node at the level. This is at the level of as a level 2 because we are dealing at the level of the hyoid. When you have when we are at the level of the thyroid cartilage or at the level of the tricort, then it becomes level 3. And if you want to know, this is the level 1. This is level 1B. This is level 1B. This is at the level of this is the anterior digastric. You have the lateral edge of the anterior digastric that forms the medial boundary of the level 1 and up to that. Then posterior is laterally it is the skin. That's the 1 region. That's not the area of interest now. This is one region. This is between the two belly of the anterior digastric and between the hyoid and the mandible. This is one region. So if you contour 1A, this will be 1 region. Okay. Now you have the submandibular gland. This is the area of interest now. This is the GTV. Now I said there is an asymmetry. Here you can see that it is more thickened compared to this right side. This is epiglottic fold here, and here on the left side you can see the piriform. So here on right side you can make out the piriform fossa. Here it is more obliterated. You can see. So the piriform fossa seems to be inward from the posterior pharyngeal violation. So this seems to be the GTV, and the node is also more prominent. You are coming to the lower end of the hyoid. That's coming to the caudal edge of the hyoid bone. So this becomes the caudal edge of the level 2. Okay. Now this is at the level of the, you are not seeing any cartilage, you are not seeing any hyoid or the thyroid or cricoid, but once you are not seeing the hyoid, then level 2 is over. And this is at the level of the level 3. This is at the level 3, same findings. Now the again, you can see that the vertebral muscles are involved. There is no plane there. It's a T4B disease. Now epiglottic fold is involved. This is the GTB and node. When you see here, you have to think that okay, there may be an extracapsular extension at the level of the. This is at the level of the thyroid notch. On right side, you can see the pyrophore fossa very clearly. Left side, it is only. So the pyrophore fossa is involved. The lesion is also extending into the paraglottic fat left side. This is the GTB, and the node becomes more extracapsular extensions. And you can see a node on the left level 3, which is at the level of the level 3 cell level. So again, same findings. Now coming to the nodes, this is at the level of the chest. This is the cricoid cartilage. This is arachnoid cartilage, and behind the cricoid cartilage, you are seeing a lesion. That's the post-cricoid. The post-cricoid region. You can see a lesion there, and the node is also showing. So this is at the level of the true occlusion, because you are seeing arachnoid, cricoarachnoid joint. This is a cricoid cartilage. This is arachnoid. This is a cricoarachnoid joint. And you can see that this is the thyroid cartilage, this is arachnoid cartilage. There is a widening of the thyroarachnoid gap. This is the normal thyroarachnoid gap. And here it is widened. It means the lesion is extending here. Say there's a widened thyroarachnoid gap. So this is a tumor there. Except again, you have to suspect in this group onwards, you have to think whether the lesion may be involved with cervical esophagus. In this patient, the cervical esophagus was not involved. Again, the post-cricoid area. So that was the GTB of the primary tumor. Coming to the node, she has shown the nodes, both the retropharyngeal nodes are involved. Where you will check the retropharyngeal nodes, you have to check medial to the internal thyroid artery. This is the internal thyroid artery. You have to check at the medial to the medial internal thyroid artery. That's the area you check the retropharyngeal nodes. So medial to the internal thyroid artery. Medial to the internal. That's the area where you check the retropharyngeal nodes. Retropharyngeal nodes arises from you have to know that it arises from it is surrounding C1, C2, and C3 vertebra. 75% of the retropharyngeal nodes are around C1 vertebra, 18% around C2, and only a small percent around the C3. So if you want to contour, then you have to take from the upper cut of the C1 to the cranial edge of the hyoid. That's the limit of the retropharyngeal. Now you have level 2 nodes. This I have already shown to you that I have already discussed the level 2. So this patient had bilateral retropharyngeal nodes, bilateral level 2, and also the patient had bilateral level 3. So the bilateral level 2, bilateral retropharyngeal, and bilateral level 3, you need to consider for the patient for a intermediate volume. That's a 60 degree. Okay. Apart from that I will discuss when we discuss the model. So again, you give another 5 mm margin, that will be your CTV 66. Okay, or a 70 degree equivalent dose. That is for the high risk volume. Okay, you give 5 mm margin. You can edit from vertical. So that is the 5 mm margin. So that will be GTV plus 5 mm margin. We give for CTV. I have not taken all the cuts because and nodes you give 5 mm margin. That is your CTV 60, or you say it as N1, CTV N1. So you have CTV N1, you have CTV N2, okay, and CTV N3 also. So 5 mm with the involved node is your CTV N1. Okay, that is. And when you have an extracapsular extension, you have to give a 1 cm. So we have given a 1 cm at the level of the level 3. So when you have the final CTV 66, that involves the primary as well as node. So you have the green one, that is your GTV. This is your CTV of the primary. That is CTV 66. You have the CTV of the node. So this is the final CTV 66. You give a margin. And at the level of the extracapsular extension, we have given 1 cm margin. So this will be our CTV 66. The node is also there. So this is our final CTV 66. Then you give the CTV 66 of the primary plus 5 mm, that will be your CTV 60. That is called the CTV P2. There are two volumes. There's two CTVs for the primary and three CTVs for the group. That's CTV P1, the CTV P2, and the CTV N1, CTV N2, and CTV N3. Okay, that I will discuss. Now coming to the CTV 60, this is then you have 5 mm to the CTV 60. So you have GTV, you have 5 mm, that is your CTV 66. Then you give another 5 mm, that is your CTV 60. Again in this cut at the level of the cricoid arch. That's at the level of 2. You can see this is the GTV. You give 5 mm margin, that is your CTV 66. You give another 5 mm, that is your CTV. So this one is CTV P1, this is CTV. And the node, this patient had bilateral level 2, bilateral retropharyngeal nodes. So this 66, the retropharyngeal nodes, the level 2 and level 3 should receive 60. There's no doubt in that. This patient had extracapsular extension in level 3. And also the patient had towards the middle of the level 3. So I thought I will give 60 level 4 also on right side. On the left side, we have given the 54. So you have the GTV node, you give 5 mm margin, that is your CTV N1, this is your CTV N2, or you call it as CTV 60. And in this patient, you have we have given bilateral retropharyngeal nodes, bilateral level 2, bilateral level 3, given 60 gray, and the right side we have given 60 gray because the patient had a level 3 extracapsular extension, and also it was seen towards the middle of the level. That's why we have given level 4 also the 60 gray, but you can argue that level 4 on this side are only 54 gray. I also agree to that. On the other side, on the level 4 and level 5, the level 5 we have given 54 gray. Here on the right side we have given 5A and 5B 54 gray. On the left side we have given level 4, 5A and 5B. So that is your CTV N1. I'm sorry, this is CTV N3. The CTV N3. So final CTV 60 will be, that is CTV final 60 intermediate scoleum will be. So you have the tumor there, green one. Then you have 5 mm margin, another 5. That is your CTV 60 covering the primary tumor as well. So this is your CTV 60. Now at the another cut, you have this is your CTV 60. So you have the green one is your GTV. The blue one is your CTV 60, and this one, the light blue one, is your CTV 60. Now coming to the sagittal view, you can see you can make correlation there. See this is behind the cricoid cartilage. This is a cricoid cartilage. So this is a tumor. This is your GTV. Then you give 5 mm margin. That is your CTV 60. Then you give another 5 mm margin all around. That will be your CTV 60. So CTV GTV. CTV 66 and CTV 60. Now coming to the distributions, okay, so this is a CTV, this is 66 gray, that's a GTV and CTV 66. The CTV 66 gray, this is covered with 66 gray. Then, so we have not given the CTV, the 98% because the CTV itself was covering filters. Then this is the PTV 66. And it was covering the 95% of the 66 day, that is 6277. The 6277 of the, that is a 95% of the 66 day. Coming to the intermediate, that is a 60 gray volumes. So this is the final, the light blue one is the 60, and this is a 98% of the 60, that is 5880. And at different school points. And 95% of the 60 gray, that is 27. So this one is this is the PT. The light blue is the CTV 60. This is covered of 57. And in the sagittal view, you can see the 66 itself was covering the CTV 66. This is 66 gray was covering. And the 60 gray, this is the CTV 60. The primary in the 588. Okay, thank you very much for your patient listening. I will be very happy to take your questions. Sorry for the sound issue.
Thank you, sir. Thank you so much. It was indeed a very elaborate discussion. If there are any questions from anyone, please feel free to unmute and ask, or you can also use the chat box. Sir, what are the elective nodes that must be treated, and what should decide the elective nodal stations what factors should decide the elective nodal stations that should be treated?
Okay. If a patient is having, say, hyperpharyngeal lesion, generally we need to treat level 2, level 3, and level 4. Okay, generally. But if you have a level 2 bulky nodes, generally we need to treat a level 5 also to a lower dose. So if you have, say, I will give you an example. If you have a pyriform sinus T3 and 0, okay, no nodes. Level 2, 3, and 4, we have to give 60. Okay, you can argue that it will receive 60 to 54. Okay, because these nodes are not there. So we can also argue that 54 is there. Okay, there is no nonsense. But if you have a node is there, that node should receive 70 Greek plus 5. That is your CTBM. That involved, suppose a patient is having a level 2, and whether the level 2, the whole level 2, need to be treated with 60 Gray or 54 Gray. Okay, that's again a matter. Okay, in our center, if a patient is having a level 2, that level 2 will receive 60. You can argue that if you give 1 centimeter beyond that node, which is seen in CT scan, it may not be needed to give 60. You are right also, because there is no randomized data to evaluate this situation. There is retrospective data showing that, okay, a low dose may be given. Okay, if you have a level 2 and patient is having an extracapsular extension, the 1 centimeter around 3-dimensional, you have to give a CTBM. That is a equivalent of 70 Gray. The rest of the level 2 we can treat with intermittent 60. Yes, there are people who treat extracapsular extension with 1 centimeter to 70 Gray dose, and rest of the level 2 to a 50 to 54 Gray. That's a low dose. Okay, I'm not comfortable enough to treat that. The patient is an extracapsular extension and at a level 2, then that no extracapsular extension plus 1 centimeter will be the higher CTB. Then the rest of the level 2 will be my CTB.
Okay. So there are also questions coming in the chat box.
Yeah.
So
if you have a cervical esophagus is involved, then you have to give a higher CTB, because then you have to thoroughly, you have to have a thin slice. Then generally you have to go a higher, because you have to account for the submucosal spread as well. You should not restrict it to 5 mm. In involvement of the post-cricoid, what nodal stations to be included? That's a very good question. In a situation like if a patient is having a cervical esophagus or a patient is having a post-cricoid involvement, generally we should consider a 6A and 6B to an low risk disease. If the nodes are not there, the prelaryngeal, the paralaryngeal, paratracheal nodes also need to be treated. Okay, apart from the nodes we have discussed. Do we need to consider parotid sparing in these cases? Okay, we can consider, because if a patient is having a level 2 extracapsular extension is there, then on that side we may not be able to spare the parotid, because we may not be able to get the constraints. You may not be able to reduce the dose to 26 Gray. It may not be possible if you have a extracapsular extension level, especially if it is an upper level. If it's a lower level 2 or level 3, definitely you will be able to spare the parotid. In this patient, we were able to spare the parotid because the extracapsular extension was in the level 3. But if you have a level 2 with an extracapsular extension, superiorly you give 1 centimeter margin, then that will be very close to the parotid. And when you take the 0.5, then again, that most of the time a part of the parotid will be your CT. So you will not be able to spare them if you have an extracapsular extension.
Uh, hello.
Yes, yes.
So there is a question that from the audience that shouldn't CTVP be edited from the air?
Okay. Yes. Yes. It can be edited. It can be edited. It shouldn't be CTVP edited from air. It can be edited. It can be edited if it's a small cut. If it's a small tumor, we can edit from the prevertebral muscles. Also, we can edit. You can also edit from the hyoid. You can edit from the thyroid. This patient had a bulky disease, so I didn't edit, to be very honest with you. But if the patient is having a very small tumor, generally we can edit. What we personally follow is that if a patient is having very advanced disease like T3, T4B, generally our priority should be to avoid a recurrence. Or in a very early disease, our priority will be to reduce and reduce the volume as much as possible. Okay, this patient was fine. Okay. Yes. In case of the ipsilateral piriform sinus involvement, should the CTV have the whole larynx or just the ipsilateral side? There is that previously the concept was that if a patient is having a piriform sinus tumor, the whole of the larynx may be treated at least to an intermittent scolia, to a lower scolia. Now the concept is slowly fading away. So if you give 5 mm, 5 mm vessels, then you can even edit from that. So to be very honest with you, we have not started editing from the prevertebral muscles. We have not started editing from the in the hyoid. Definitely we can edit. Thyroid we definitely we can edit. But we have not started editing from the prevertebral muscles or from the medial pterygoid because of the concerns that in Western population, in all this, they have very stringent criteria and they have a very good team for salvage. Here, in our situation, most of the patients, if there is a residual disease, even if the patient is if there is a slot, there is expertise available, the patient may not have enough reserve to undergo that. Number two, there is a waiting period for doing a salvage surgery, and there is a morbidity is involved in that. So a lot of concerns are there compared to Western population. So before incorporating all this into our clinical practice, we have to adopt what is the facility we have. I think we have discussed most of the, shall we wind up?
Hello.
Okay, thank you very much for the for joining for this meeting. Okay.
Hello. Hello.
Yes. Yes.
Your voice is yes.
Can you hear me now?
Yes, sir. You are audible now. Yes.
Okay. Shall we wind up now?
Okay, sir. Sure. So thank you so much, sir. It was indeed a pleasure, as always, to listen and learn from you. And thank you so much. And thank you, Dr. Gayatri, for presenting the case very well. So thank you, everyone, for joining in. See you next time. Thank you, sir. Good night. Yes.